All right. Like we got one more joining. We have somehow fixed that we don't have to let you in the waiting room anymore, which is kind of nice. Yeah, magically disappeared. All right. Well, I do want to get started and be respectful of everybody's time. The good news is, Perry, we can probably have a pretty good discussion and kind of make it a little more intimate in terms of going through some of the results that we're going to be going through. So, good morning, everyone. Welcome to the March meeting of the Primary Care Payment Reform Collaborative. Happy to see you all this morning. Quick note for new faces, we do record these meetings. That is for the division's internal purposes only. The recordings are not posted or shared with anybody. Those are really for our internal housekeeping purposes so that we can have some pretty honest and open discussions. So with that note, we'll go ahead and get rolling into our agenda for today. So what we have slated to talk about, first up, we're going to be hearing of the evaluations of a couple of practice transformation initiatives here in Colorado. So we have some guest speakers that are on the line and will be joining us for that. Wanted to put them up first so they don't have to stay around for some of the housekeeping announcements, but we do have some business to take care of with you today. Part of that today will be going through our standard operating procedures and rules of order to make some updates there. Then do have some federal and state updates to go through, and then we'll round out the meeting really getting into a deeper dive on your priorities that you want to focus on in the upcoming year. We'll share some results for the survey, kind of see what's surfacing to the top, and that will help us start plotting out our agenda for the year. As always, we'll make time for public comment at the end, but the collaborative appreciates others joining. So if any members of the public at any point want to chime in, please feel free to either raise your hand or just take yourself off mute to offer questions or comments. We do have a little bit smaller group so far this morning, so please feel free to jump in. We're going to be hearing some really great data, but data can get in the weeds. So if you have questions or things to flag, please feel free to do that. All right. In terms of being very upfront about kind of meeting and what we hope to get from you, our goals and our requested feedback. Really, we want to hear some evaluation results about some great work that's being done here in Colorado. So we're hoping for some good Q&A for our presenters today, and then really trying to think about what implications this data and practice transformation and kind of the approach that was used both in practices and with the evaluation to finding kind of what implications that may have for your work. Again, we do have a housekeeping announcement to get our SOPs updated so that when people are reviewing your fabulous recommendations report that was updated, when they're clicking on that link, they're getting an updated copy of those. And so we'll get those hopefully finalized by today and posted on our website. And then finally, really getting in, always an exciting time of year when we have the report in the review mirror and can really focus on what you all want to talk about over the next several months. So with that, I will turn it over to our presenters. I'm going to start with a little bit of a personal point of privilege and possibly very much embarrass Dr. Dickinson, Perry Dickinson, who is joining us today. Wanted to note, I got the opportunity, privilege and honor of meeting and working with Perry when we were part of the state innovation model together, but he will be actually retiring after almost 27 years with the Department of Family Medicine at the University of Colorado at the end of the month. So we are very lucky. It almost gives me chills, Perry, that we're your last official presentation to be giving in this capacity. Perry has been the past president of multiple state and national societies. He's received numerous research awards, the 2024 Maurice Award for Lifetime Contribution in Primary Care Research from the North American Primary Care Research Group, and has done just an amazingly wonderful human to work with and an amazing asset both for the state and for the nation in terms of really advancing primary care. So Perry, a very warm welcome, and I will now turn it over to you to get things rolling. And if you just say next slide, I can go ahead and try for you.
Good. Oh, Tara, thank you. It's been a privilege to work with you over the years as well. So shared feelings there. You can go ahead to the next slide. So and I'll get into some of the details of this particular project in just a second, but just wanted to point out that we've used practice facilitation a lot in this state. We started building it a lot in the early 2000s, actually, with Health Teamworks really particularly taking the lead initially on that. We worked with them extensively on a lot of projects, and then that spread across a lot of different groups in the state that have done wonderful work supporting practices through providing people to go into the practice and help them to implement change, implement new models of care, new evidence-based interventions, that sort of thing, but also in doing quality improvement and teaching the practices how to manage change during a period where there is a lot of change. And improve the quality of care for their patients. And there are a lot of studies that show a positive impact of practice facilitation on implementation of change, but also quality measures, including a number that we've done here in the state, kind of repeated positive findings there. But there are not a lot of studies that have looked at the impact of a practice facilitation and other practice support sort of interventions on utilization patterns. Next slide. So that's what we are focusing on here. I'll present a little bit of data regarding the impact of this project on implementation of kind of a new model of care. But I'm going to particularly focus on the impact on Medicaid utilization. So the Innovation Support Project was one that we did in the immediate follow-up to the State Innovation Model Project. There was not funding at that particular time to continue SIM, but were able to get some funding through CU Medicine, specifically using some upper payment limit funding that they get through Medicaid. And with that support, we kind of continued a slightly amended version of SIM. It was not as focused on behavioral health integration. It was more focused on a bit more on the general sort of package of preparing for alternative payment models in general, but also in particular preparing primary care practices for Colorado Medicaid's APM. It began in October 2019. And with a little bit of a delay because of COVID, we had practices kind of poised to get started fairly early, toward the end of 2019, and then COVID hit. And so we really didn't start our practice transformation support for the practices other than a little bit of support for implementation of telehealth. Until July 2020. And then this ran through June of 2023. So really a 3-year period of support for the practices. We had a change package here that really focused on a set of implementation milestones that was based on the Bodenheimer building blocks of high-performing primary care. Those of you who are involved with SIM will remember that the multi-payer collaborative as part of SIM came up with a set of milestones that then my team also modified and provided input in, and that we then used as the basis for a lot of the support that we provided the practices as part of SIM. We took those and modified a bit, actually getting back a little closer to the original Bodenheimer building blocks, aligning there, but still maintaining some of the behavioral health focus there as well. So again, we're going to focus here on utilization. Next slide.
Barry, can I just hop in here?
Sure.
On that, in terms of the change packets and those Bodenheimer building blocks of primary care, kind of a connection for members here to be making. When you think about our aligned APM parameters, we have a section within that regulation that talks about aligned core competencies, where it lays out various kind of activities and milestones. There's kind of a tiered framework. So there's not, I think we can share the exact ISP building blocks if folks are interested in that. And I will note there's not a direct correlate. They don't overlap completely, but there is a great degree of overlap. So kind of as you're thinking about this, kind of the way that we have gone with that regulation, what we have in place right now in terms of thinking about what practice facilitation could look like and the types of activities and competencies you want to be supporting practices and achieving, it's very much aligned with this work. So that was kind of one of the reasons that I was particularly interested. While this particular presentation on this data is focused on Medicaid, kind of through that regulation is the way that we're kind of expanding that and thinking about aligning that across different payers. So I just kind of wanted to make that connection in your heads right up front here. So, all right.
I'd say that the alignment is pretty much perfect, kind of along. The main difference with the milestones used in this project is that there were probably a few more detailed sort of milestones that we used, or care expectations is the language in the regulations, than the care expectations have. But great alignment. We can go, yeah, there we go. So the practice implementation support that we provided to practices as part of this project included, obviously, practice facilitation using all of our partners across the state. As most of you know, with the Colorado Health Extension System that we convene and support the convening of. We have relationships with really about 20 at this point, what we call practice transformation organizations across the state who field practice facilitators to support practices. And for SIM, this project, and other projects, we've used them. We take the money in through grants or whatever, but then get the funding out to those organizations to provide the direct support to practices. So there were monthly meetings for the practices with practice facilitators, usually with an implementation team within the practice, sometimes in person. With this being right post-COVID, most of them were virtual, but typically a little bit of a blend. We also did use our regional health connectors across the state, who is a workforce that we were able to establish during the State Innovation Model Project as well. They're spread across the state, and they're available to us, in particular in this project, to assist practices in connecting up with community resources, and particularly to address health-related social needs. And then we did have some practice learning community activities. Those of you have kind of been part of previous projects. We had planned on having yearly in-person meetings. In this project, that wasn't initially really available. So we instead had regular meetings that were largely virtual for practice training and for practices to share their experiences with each other. Okay, next slide. So just a quick one on some of the practice characteristics. We had 122 practices that actually were provided practice facilitation in this project, with most of them continuing for more than a year, probably a third of them for all 3 years. The practice sites, a mix of rural and urban. We had a mean percentage across all the practices of patients with Medicaid or dual eligible of 34%. I mean, that was there. So a heavy Medicaid or dual eligible sort of payer mix for the practices. And with 362 plus thousand Medicaid members who were attributed to ISP practices for one or more quarters during the project. Practice types, a lot of family medicine or mixed primary care, internal medicine, pediatrics, and a mixture. A good solid contingent of general pediatrics, and we were really pleased with that. I think in follow-up to SIM, we'd gotten a foothold with pediatric practices a little bit more than with preceding projects, and that continued through this project with a good engagement of pediatrics, and you can see the others there. Next slide. And just quickly, organization types. I would say comparing to what was there in the state at that point, and that continues to change, we probably had a little bit higher percentage of clinician-owned or independent sort of practices, and less of the health system-owned, although a good mix of all different types. Next slide. So in terms of the building blocks, just the traditional 10 building blocks that some of you will recognize. I'm not going to go through these in detail, and you will have the availability of the slides to look at, and if you want to look at it in more detail. But just to say, again, we had very good improvement across all the different building blocks. All of them were highly significant, and this is probably pretty much in line with what we saw in the State Innovation Model project as well. A little slightly different set of building block of milestones in some of these, but very similar and similar results as from there. And again, these are the practices ranked themselves according to their implementation of the various milestones according to just how extensively they had implemented each milestone in their practice. And we repeated it every 6 months. And this shows the improvement from baseline to the final. It says most recent, but it should be final there. Let me pause for just a second. Any questions so far? Why don't we go to the next slide? All right, we also did separating out what we did here is we kind of put the behavioral health integration items from SIM kind of back into the 10 building blocks. But we did do an analysis where we separated out the BHI or behavioral health integration related items, and the practices did show a good bit of improvement in that area, even though we weren't really focusing specifically on that area. Plus, we had done a fair amount of work toward the end of SIM around substance use disorder, and we added in some milestones around substance use disorder as a separate optional building block here. And the practices made good improvement there. Again, that's an area that we learned from SIM really deserves some more specific attention than just general behavioral health integration. Next slide. And 2 other areas real quick. Health equity and health-related social needs. We did health-related social needs we added in at the beginning of the project as an area of focus, and we were really interested and pleased to find that a number of practices really focus quite a bit of energy into that level. And into that area with substantial improvement in implementing a focus on how they screened for and helped patients with health-related social needs. For the last year of the project, we added some milestones around health equity and inclusivity and saw some improvement there. That was our first dip of the toe into that area. That's areas for specific work, and we're pleased that we at least learned a lot, and that saw some improvement with practices, with the biggest barrier being their ability to get good data out of their EHR systems, which continues to be one of our biggest headaches all across the board. Next slide. So now let me move into the cost analysis. I'm not going to go into detail for this because it's complicated, and I'm not an expert in counterfactual analysis. But basically, I'll look at this bottom line. It's a method that really is used to, when you don't have a classic randomized trial or something, but rather an intervention that you're doing kind of with kind of a mix of practices without randomizing. You can estimate the impact of the intervention even without that classic control group. And it's very, very commonly used in economic analysis. This is one of the key analyses that is used to determine the impact of projects out in the community on cost. Next slide. So for this project, we extracted the data from the Health First Colorado data warehouse for all members of Medicaid, Colorado Medicaid, who are attributed to a primary care medical provider from January 2019 through June of 2024. So we went back a year and a half to look at trends kind of coming into the project, and then looked at the trends going through the project in a year post after the project. Patients were assigned to a participating practice who participated in ISP. For this analysis, for any quarter they were attributed by Medicaid to one of those practices, again, during and 1 year after the practice's project participation. I think we can go to the next slide. So here's the bottom line sort of analyses. We didn't analyze every different area of cost, but total cost of care, we saw for the patients who were attributed to practices who participated in ISP, we saw almost $10 per member per month less cost, basically. And we can go over what that represented in terms of total cost savings in a moment. Interestingly enough, the primary care cost went up slightly, which actually you would potentially hope for in this sort of intervention. Pharmacy costs were obviously down quite a bit, as you'll look in a second at visits. Some other things around emergency room usage, some things like that went down also, although we don't have that in the cost. We looked at that by actual visits. Let me pause here and see if there are any questions before I go to the next slide. A lot to absorb here, but here this cost delta, the decrease or change in costs are the key ones. Yes, Dana.
Yes, thanks. Dana Pepper from Colorado Access. So, and I'm curious about, in terms of the participants being attributed to primary care during those years. Everybody was attributed in those days, right? They were auto attributed. So now they're not, which is a whole other story. But I'm curious, they were attributed to primary care, and then did you also look at they were attributed in that they'd had a plurality of visits and like they were truly tied to that practice, or they were just kind of categorized as attributed? Do you know what I'm saying?
We went by the categorization from Medicaid,
Okay.
which probably actually
impactful. Yeah.
Yeah, it probably decreases the impact.
Yes.
Because a number of the
That's
patients.
what I'm thinking. I'm thinking you would have had even more impact had they been kind of closer with that practice than just being formally attributed. So
Yeah, I absolutely believe that.
me too. Yeah. Thanks.
Any other questions before I move to the next slide? All right, you can go to the next one. So this looks at encounters and basically is the difference, kind of a convenient way to look at it. The difference in visits per 1,000 members per month. So ED visits for all 1,000 members each month, 4.3 less emergency room visits. Actually, interestingly enough, less primary care visits, which, considering the increased cost for primary care, I think infers to me that practices were doing a better job of providing a fuller set of services to patients when they did come in, which is kind of what you would anticipate from implementing these sort of models of care. Primary care telehealth, we spent a good bit of time, during the COVID months supporting practices and implementing telehealth, and that shows here with almost 3 more telehealth visits per 1,000 members per month. Capitated behavioral health, which is mostly non-primary care, actually decreased. And again, I think probably because behavioral health services were being provided more in these practices. We had an analysis trying to look at that. That's a little difficult to get because of the things that are billable around behavioral health integration. Some things are, some things aren't, but nevertheless, we did see a less use of capitated behavioral health. Let me stop there for a moment and see any questions before I move to the next slide. All right, why don't we go to the next one then? So the implications for Medicaid expenditures, we had a total number of Medicaid patient months attributed to the ISP practices of almost 7 million. So do the math, multiply that out by the per member per month savings, and this was almost $68 million just, and again, this is just for the period when the practices were participating, anywhere from actually 6 months up to, for a few practices, 3 years, and then the year following. So for that period of time, almost 68 million. We also saw that we were real interested in looking at what happened during the project and then what happened for the year after. And we found that those savings were not significantly different. The savings continued after the term of the project. That's always, so practices kept doing what they were taught to do and what they implemented during the project. We keep having all these projects where short-term look at cost, impact of a project on a variety of different outcomes, and they don't really run it out from there. At least here we were able to run it out for a year post and saw continued savings. And so those savings are likely to continue even beyond that, I think, although we can't look at it here. So the further savings were likely to continue in subsequent years. Next slide. So just basically as conclusions, I think this sort of practice transformation support that's focused on practice facilitation to help practices in implementing new models of care, building blocks or whatever, can result in some substantial cost savings. And these cost savings were pretty similar. We saw different results in Colorado SIM from different analyses, but what we see here is similar. We actually did a similar analysis of our own on Medicaid data from SIM and saw very similar results, bottom line. Yes, Dana.
Yeah, I just have another comment. So I love this. So this is great. And this is deep in what we're doing all the time. So this is really interesting to me. And one comment I have around your last bullet in terms of investments could potentially result. So, over the past couple of years, there has been pretty substantial investments from the raise regarding integrated behavioral health, right? And paying a PMPM to support that model. And so we've been studying that as well. And that just strikes me as one key investment in this is that those ongoing investments, I totally agree, will result in those cost savings. And we already see that in a pretty short period of time, but over a long period, I think when those become just more standard in certain practices, we'll see even more. But I think trying to figure out where to invest is critical. So I think it's the bullet is certainly general, but couldn't agree more that we need to think about those investments.
Yeah, I agree completely. And we can talk, we'll actually we won't present cost data from 1302 from the Behavioral Health Integration Project, but we'll present some other data here in a moment.
Right.
I do want to point out that we can't really separate out the impact of the various aspects of the practice support intervention. So we had regional health connectors, we had learning community activities, but big focus on practice facilitation. I think the bulk of it was practice facilitation here for this particular project because of its focus, but the regional health connectors in particular may have contributed a good bit as well. One other thing I'll point out is we have we had CPC Plus in CPC that were pretty extensively evaluated with national evaluations that didn't really show very impressive practice cost improvements or practice changes in general. I would have to say, and practices that participated in those can argue with me if you would like, and I'd love to hear it. But my interpretation of the practice support for the practices, that were involved in those projects is not nearly as robust as what was provided here or in the State Innovation Model project. And that, I mean, one of my interpretations is unless you do more robust support for practices, you're not going to see the cost savings or the implementation levels that you do otherwise. But that's, again, that's more the discussion section. I can't completely prove it here.
And just for those who don't know, Perry, you now owe something in our acronym jar. For those who don't know what CPC and CPC Plus are, so the National Centers for Medicare and Medicaid Innovation, which puts out a lot of the payment models. One of them was called one was the way there were two. There was one called Comprehensive Primary Care, which is CPC, and that was followed by Comprehensive Primary Care Plus. And both had pretty robust participation from Colorado and kind of got a lot of practices on this track. CPC Plus sort of overlapped with our state innovation model, and kind of CPC was its predecessor. So just a little bit of orientation there.
Sounds great.
Yeah, and there are a couple of questions in the comments. David, we could potentially break it out for pediatric practices. It would require, God, these analyses take forever to run. They're huge data sets and take forever. I mean, talk to Mark Greitz, and you could even talk with me. We could both talk with Mark and see. Yeah, we could probably do that if you think it would be of value. I don't think it was strikingly different as we look at how some of the practices implemented things across these projects. Pediatric practices tended to start as refers to Cassie's comment. Pediatric practices hadn't done as much work in these areas coming into SIM and then this project as family medicine in particular, because most of the previous initiatives had been really pointing toward chronic care model, adult patients, et cetera. And so in general, in SIM and here in terms of their implementation outcomes, at least, they started off lower, but implemented as much or sometimes even a little bit more than the other practices because they had a little lower baseline. I would anticipate that the impact on costs would be very similar in the pediatric practices.
Well, particularly because you're looking at mental health stuff, and that's something that SIM didn't do very well. We didn't have access to the data.
Yeah, that's correct. Any other questions or comments on this one before we move to 1302?
Perry, I just had a follow-up question about the health-related social needs. That seemed like one where there was a significant improvement between kind of baseline and state, and kind of what that looked like. Was that primarily just improvements in screening, or was that improvements in screening and then actually making connections in communities, right? The collaborative a couple of years ago, one of the reports was, yes, we would like to improve health-related social needs screening, but very cognizant of that's only the first step. And if you're not actually making those community connections. So it was just a little bit interested in kind of what that looked like, and if there were any good success stories about people being able to kind of get to community resources and creating those closed referral loops.
Yeah, we've actually looked at that data a good bit and have a paper that we may or may not get to around some of that because it was new. I mean, we really hadn't done as much focused work on health-related social needs. Practices that we had a set of practices that I think had, we had overlap in this project with SIM and other projects. I mean, we have practices who really have capitalized on practice facilitation across multiple projects. And a number of those that had done some of the previous work really put a lot of energy into screening for and trying to deal with health-related social needs. It was a subset of practices. It wasn't all practices, but I think I would say that a lot of the practices at least started doing some screening and some work there. But we had a set of practices that really dove into that work. And it was both screening for, I mean, obviously that's the first step. If you don't know, you can't do anything with it. But then also using the practice facilitators to help them to connect up with community resources. And that's really where the practice facilitators add a huge amount of support for that lift. Any other questions before we go on? All right, next slide then. Yeah, we can go on and can go to the next slide. So just to get to the acronym, House Bill 22-1302 was the Healthcare Practice Transformation Act, and it provided funding to HCPF, to Colorado Medicaid, for a large-scale project supporting primary care practices to implement behavioral health integration. A good follow-up project to the State Innovation Model Project that was, if anything, even more focused on behavioral health integration. Those of you who participated in SIM may remember that it was a little bit broader. It was looking at broad-based practice implementation of, the building blocks which are aligned with the patient-centered medical home, but with a focus on behavioral health integration. This was particularly focused on behavioral health integration. 144 practices participated and received practice transformation support from our team. Again, using the same network of practice transformation organizations and practice facilitators as I described earlier. Next slide. So the implementation support, again, same as almost the same as the last one. First of all, practice facilitation with monthly meetings. We had 2 annual collaborative learning sessions where we gathered the people from the practices together for training and sharing. We had an additional virtual practice learning, had additional practice learning community activities, virtual ones, in between those in-person collaborative learning sessions. We have a pretty extensive package of e-learning modules that we built across multiple projects, including SIMS, with a lot of things focused on behavioral health integration, and that practices and the practice facilitators had access to those. And then here we use a change package that was based on the building blocks of behavioral health integration. These we developed after SIM ended, really looking at, just focusing on the various milestones or care expectations that were focused on behavioral health, and separating those out and using our experience from SIM and other projects to really focus those a bit more. Why don't you go to the next slide and we can talk about those in a moment. So here we had some general areas: leadership. Things about leadership focused on behavioral health integration. For example, providing resources to the practices specifically focused on that area. Supporting how much the leadership actually supported that work. Data-driven quality improvement focused around behavioral health measures and working on those. Team-based care, you can see those. So team-based care, patient and family engagement, population management, access to care, again, all focused around mental and behavioral health. Then we separated out three key areas that for this project were optional depending on the practice goals. Let me talk about those for a second. Certainly we learned from SIM, and we knew this going in, but learned even more, that all practices can't do, every practice can't do the exact same model of behavioral health integration. Some practices don't have access to a behavioral health provider locally to integrate into their practice. If practices are trying to do the collaborative care model, working with a psychiatrist, you have to have a psychiatrist available who's willing to work with you, etc. So we separated out 3 key areas. So these general areas up in here, we expected from all practices. This is stuff that's basic to working on behavioral health within a primary care practice. But then, depending on the practice goals, there are care expectations around implementing advanced coordination and care management for behavioral health conditions within the practice. A full integrated model where you have an behavioral health professional working inside the practice, seeing patients, doing warm handoffs, etc. And then implementation of collaboration with a psychiatrist, largely through the collaborative care model, although some practices actually had psychiatrists coming into the practice. So those are the modified building blocks for behavioral health integration. Next slide. And by the way, this particular model that we used here, we vetted with a lot of national experts, both payers across the country, but also a lot of both primary care and behavioral health experts in behavioral health integration, just to make sure we got them right. It was supported by Wellbeing Trust. I could send out to folks that package if you would like to receive it. There's a kind of a package around this that is online and published. So we had a building block assessment rating similar to what we used for the milestones in the previous project. Practice rated their own implementation of the care expectations or building blocks. First of all, that they hadn't even started it and had no progress toward implementing them at all. They're just beginning to work on it, actively addressing and making good progress. And then finally 3, which is complete and implemented across the entire practice. So again, this is really focusing on the practice's assessment of how well they have implemented these various care expectations. Same process that we used in the previous project, but just going into a little bit more detail here of the process. We use these rating scales and this framework both in training the practice facilitators on this work, and we had regular meetings with them to train them and discuss them and make sure they understood them well. But also the practice facilitators use these in their work with the practices so that they use it to guide the work of the practices. And so when they do at every 6 months, they do their rating of themselves. They'd also use that to plan, okay, what are we doing well? What have we not started yet? So they could guide their next framing of the work as well. Next slide. So this is a cluttered slide. I'm going to show it in a different way in a moment, but just 2 different ways of showing it. This is looking at the care among the care expectations for each of the areas, the % of them that were completed, not just rated as a 0, 1, 2, 3, but is rated as a 4, that they had it completed and implemented across their entire practice. And you can see the progress across each of these. We had less practices that focus specifically, as you will look out here to the right, on implementing the collaborative care model. But we saw a lot of advancement there for the practices that did work on that. And one of the things we found in separating out the practices that just chose working on a collaborative care model as one of their particular goals that they wanted to work on. We showed a little bit more advancement there, but we really saw advancement for all practices in that area as you looked at it. It's significant improvement there. Same for advanced care of substance use disorders, which I didn't have on the previous slide, but was another area of emphasis or focus that practices could do. Again, I don't think in SIM we did as good a job with a focus around substance use disorder, and it was heartening to see good advancement there because I think that's been a little bit of a gap with some of the work we've done around behavioral health integration in the state, and we're seeing better advancement there. Let's go to the
Does that
next.
include MAT, Perry?
I'm sorry.
Does that specifically include medication assisted treatment? Does that include MAT as part of that?
It does. Yes.
Okay.
Now, and you know, we've had enough projects. You know, we had some other projects that we did as for our team around implementation of medication assisted treatment. And I think we've gotten some foothold there at least. I think policies have made it a little bit easier for practices to do that. And we are seeing advancement in that across the state, but still not where it needs to be.
Yeah, no, that was a recommendation included in a report a couple of years ago. So it's interesting to see about that here now. All right, you said next slide, right?
Yes. So this is just another way of looking at it that's a little bit more comprehensive. The orange is, you know, the rated it is not started. The lighter the orange is just beginning, light green actively addressing, dark green complete. And so you can see the advancement in those areas across all of them. Again, practices started out a little, you know, started out lower with psychiatry and substance use disorders, didn't make it, but made substantial improvement. Full integration started out a bit higher because of SIM and other projects in the past, but we had more practices that really focused on trying to implement a fully integrated model here and saw good improvements there. All right, next slide. Let's skip this one. I kind of talked over that one already. So we also did quarterly snapshots with the practice facilitators reporting on what were the goals that the practices had, how the practices had done on the goals that they had been working on for the previous quarter, but also what were their now, you know, were they keeping the same goals or had they come up with new ones for the next quarter, just to see how their work was progressing. And so here I'm just going to give a quick view of what the practices goals were, and then what some of the challenges were that were reported in those quarterly snapshots. Next slide. So again, we have a list of goals. For those goals, we would look at, for the ones that they said, if they said they weren't working on it this time or the goal's been achieved, we didn't worry about it. But for the ones that were, for these, we tried to look at the challenges that they face. So we are here reporting both the goals that they reported, but also the challenges. Next slide. And next slide. So this was done through a qualitative analysis of these quarterly assessments and categorized each of the goals and challenges for you know, what was the best description of them, and then looked at the percentage of the goals for each category. Next slide. Go on through, and I'll just get to the data here. So there's another slide with the rest of the list, but these are the goal types that were described out of almost 900 goal statements for these practices that were reported through the project, just the overall frequency at which we saw these particular goals. Training, education, onboarding, a common thing they worked on. Hiring, recruiting, and contracting, a big issue, you know, just trying to identify the resources and contract for them or hire the people. Ongoing quality improvement, working on workflows and processes within the practices. Patient outreach, you can see on down the list. Billing, coding, and documentation, a big one. Now I'll leave this up for a second and then we'll go to the next one again. You can look at it in more detail, you know, with the slides that you'll be provided with. But And go to the next one. And here are the rest, just to kind of give this reported. We did do some support for practices around health-related social needs. Some practices had those as goals that they were working on during the project, but less in this project because it wasn't an area of specific focus here. But and we didn't have specific funding for the regional health connectors here. But all right, why don't we go to the next slide then, and we'll finish this out. So these were the challenges practices reported. Some practices, for the things they were working on, or for some of the goals that they were working on, never reported a challenge. But going on down, hiring, recruiting, and contracting, huge challenge still. There are not enough behavioral health professionals, particularly trained in working in primary care practices and this sort of integrated care. There are just not enough out there. And so identifying and hiring people was a huge issue, or contracting with psychiatrists for collaborative care model, still a huge issue in this state. Time constraints, everything takes too long and with too little time. Billing, coding, reimbursement, funding, still a big issue. A lot of and that was an ongoing thing that we provided a good bit of support. We had people working to both in terms of presentations around how to bill and code effectively, and also providing individual practice consultations there. But still, huge issue, particularly as things changed over over the course of the project, because it's a shifting landscape in terms of reimbursement. Turnover, you can see them on down. Let me see if there are questions on this real quick. Just pause while people look at it, and then.
Carrie, this is Cassie Littler. I was just starting to write in the chat, but I think the change in codes was really particularly difficult, I think, for practices for Medicaid in July 2020 of this last year. And then just, the difference in coding, what's billed to commercial insurances versus Medicaid can be different. And I think that's just such a tough landscape. And so I appreciate that was part of this, because that's the only way to continue to sustain these programs.
Yeah, and we've completed our practice facilitation for this project, but we have been continuing some of our sessions around coding, and particularly with the changes that happened last year. Practices are still adjusting to everything there. So we really wanted to provide at least some learning community activities that practices could attend if they were continuing to have problems. Pam Ballou Nelson is a phenomenal resource we have here in the state that we've worked with extensively around these sorts of things, and has been extremely helpful. And in a separate project, we are working with the Rays around the same issue, trying to train the people who work with practices in the Rays. And as Allison says, we still have some resources through some of that other projects to work around coding support through June at least, and maybe beyond. Why don't you go to the next slide, and I want to just point out one particular thing here. Credentialing, licensing, and certification. In SIM, this would have been much higher. So getting people credentialed, you hire people and then have trouble getting them credentialed to provide, to be able to bill for behavioral health services. Huge issue in SIM. There, of course, you are working across multiple different payers. This is specifically, mostly at least, referring to Medicaid, since it was a Medicaid-focused project. But nevertheless, I think there has been advancement there. There was a lot of work, particularly in the latter stages of SIM, in that area. Still an issue, but less than what we saw in SIM. And you can see the others.
Well, there's a bill that we're going to be talking about in our state updates later that's actually specifically looking at credentialing for behavioral health providers in the state of Colorado that is currently working its way through the legislature. So,
yep, good thing to hear. So that's all for let me see if there are any questions beyond the ones we've hit so far. I just would like to say, we've been fortunate here to be able to capitalize on a number of initiatives to provide support to the practices. First, obviously, the State Innovation Model Project, Transforming Clinical Practice Initiative that happened at the same time as SIM, Evidence Now, which was focused on cardiovascular health through AHRQ. Then we got the funding through CU Medicine to do ISP, which we reported on initially first, and then through this project for behavioral health integration, continuing some of the work. We don't have that at the moment. There was a huge AHRQ focused project. AHRQ has funding to support health extension work, providing support to practices like this. But it's sitting there fallow. They're not doing anything with it. There was an initiative that would have provided us with a big chunk of money to really take this a level further, if anything. And it's being sat on it within the money's accumulating because it's a source of funding that comes in through no matter what. It's not contingent on the legislature, but we'll see what comes up over the next year or so. They have been instructed to start releasing those funds and doing work, and we're really very well focused, very well positioned here in the state to capitalize on those projects. But at the federal level, I'm not seeing much happening, right now, unless that starts coming through. And at the state level, there's nothing kind of in the immediate landscape. So I think we're going to have a little bit of a gap, but we're going to keep the fires burning and keep the Colorado Health Extension System and the work that we do alive as much as we can through the next little bit, so that when funding does get released and there's actually opportunities, we'll be able to capitalize on it. So I'll stop there unless anybody has questions.
Is there any part of this that's like looking like any money that you have to look? And I know there's a gap and there's, funding that's not being utilized, but like to look 5 years down the road to say, hey, these practices are continuing to do this work, or they've lost their, funding and they can't do this work, just to kind of look down the road to see what's actually happened with all of the training if it continues.
Cassie, that would be a really good thing to be able to do. I'll plant the seed for that. I'm about to retire, as Tara indicated, but yeah, I might even be pulled back in for that one. I would love to look a couple of years down the road, at intervals, and take some of the, we're actually currently trying to do a project. We know that we've had practices that have worked on with us through these various initiatives through multiple projects, and trying to look at some of those practices and how they've advanced across time. We're trying to kind of tease things out to be able to do that, but it would be nice to then also look, okay, without the support, what's happened. There are also practices out there that we haven't worked with yet, that haven't really engaged, and we know that some of them haven't done much of this work. That's as much of this implementation work. So yeah, it'd be nice to be able to identify what made the biggest impact across programs. That starts becoming pretty complicated analyses. We do have databases that could be used for that if we have people who are especially interested. So, do doctors ever really retire? Yeah, I think so. But I'm still around. For any of you that my email address will still be the same, and I'll still be keeping up with what's going on. And yeah, just if there's any way I can help out with some of this stuff, it's been kind of at least the second half of my career, this has been my life's work. So I'll be around.
Any other additional last questions for Perry?
Thanks to all of you on the screen for the support you've kind of given for this work and practices engaged, but other people who are policy leaders to kind of support this work. It's been, I think, important, and it's been good partnerships, and hopefully everyone will continue with this partnership in moving primary care forward here. So thank you.
I mean, it's an ongoing journey, right? When anybody asks me about my job and how I describe my job, right? This is the latest chapter in Colorado's journey toward improving primary care and advancing payment reform. And I think kind of part of the reason with these presentations is really drawing those through lines, right? You know, from SIM, and we've been able to build this now here. The tool that you all have and this group has now is we do have aligned payment parameters as a piece that could be help advancing this and help to be, looking at a different way of creating payer alignment to get to sustainable funding sources. But still, you know, practice transformation is hard work and it requires funding. So I think it's continuing to look together to see certainly payment and aligned payment is important in supporting these, but you know, also part of this is what is that infrastructure investment in primary care that we want to be thinking about, and how are we thinking about maybe capturing and showing some of this as we're thinking about a state primary care course scorecard and things that we want to be assessing in terms of, I know there were some ideas about metrics about practice readiness, but then is it also important to think about things like what are outcomes? Are we actually having data? Can we be able to show these types of results as well? So kind of a whole bunch of things that I thought were great in this work that I wanted to make sure you all have access to. And we're not done yet. We've got a part 2 on 1302. I have some additional guests with us here this morning, Nathan and Teresa from HICPUF. So I am going to kick it over to you all.
Thanks, Tara. My name is Nathan Drashner. I know many of you. I was the data evaluation manager for SIM, actually, previously to my work, moving over to HICPUF to work as a contractor. So almost all my work is with healthcare policy and finance in the state of Colorado as a contractor. You know, my background obviously is working in data evaluation, and they contracted with us to do the data reporting for the 1302 grant. I'll let Teresa James introduce herself. Teresa, you want to go ahead and tell a little bit about your background and what you bring to the table?
Hi, good morning. My name is Teresa James. I'm pleased and to be there here with you. I've been a licensed clinical social worker for over 30 years, which tells my age a little bit along the way. I've spent 20 years in hospitals. I've been 8 years in state leadership with human services. I worked on a state SIM implementation grant. I have been responsible for 8,000 foster children and their families regarding their health and behavioral health services. So I'm glad to be here and to be a part of the 1302 evaluation.
Yeah, so we recently, a couple months ago, had a mid-grant data report that we turned in, and we're going to kind of talk over a little bit of some of the things that we saw and that we put together. On this slide, we have a few quick highlights from what we analyzed so far. Among our 78 grantees, about 1/5 are nonprofits. Very small portion are government entities. The majority operating as for-profit, of the rest are operating as for-profit organizations. Most of the grantees, 62% are the expansion track, while 35% are new implementers. That is to say that the expansion track is previous SIM participants. The 35% are new to the game of practice integration. So primary care practice integration. The primary care behavioral health model is the dominant evidence-based research approach used by over half the respondents. On an average, Medicaid patients make up about 47% of the grantees, the patient population. Some of the clinics serving as few as 11% of the Medicaid patients, and others are serving nearly all. So we really run the gamut of provider types. For this slide, just so you're aware, we use the Colorado Rural Health Centers, CRHC's definition of urban versus rural. They define rural as a non-metropolitan county containing no municipalities over 50,000 residents. We also did Frontier, just take a look at it, but it was such a small segment that we decided not to break it out. So next slide, please. So when we started on the project about a year and a half, 2 years ago, one of we started looking at the legislation in comparison to the work that had already been done. And one of the big areas that we kind of saw maybe a gap that was a little concerning, we wanted to make sure we supported well, was access to care. We didn't really have the greatest way or path forward to get to access to care. And that was a pretty key piece of legislation that we really needed to answer to in support of HICPUF. So we really started looking at how we could do that. Maybe different ways we could get at it. Access to behavioral health care services. Looking at claims. For the number of visits. Trying to get at wait time for appointments. Unique patients accessing behavioral health services. That was another way we could get at it. Some of the resources we thought we maybe could utilize to get at that is the behavioral health provider counts that are out there, what types of claims codes they're pushing at, and then obviously the volume and the reimbursement amounts. But even looking at all that, we felt like there was still some pretty big gaps. Can you please go to the next slide? Currently we really only have range estimates, as far as like the number of providers, like 1 to 2 to, 4 to 5, that type of situation. Because of that, we're not really able to report real successful in FTE staffing, or the direct impact of the grant on the clinical care delivery. We also don't have specific data regarding children or pregnant postpartum individuals served right now. To address these missing data challenges, a lot of it was created by the fact that we just didn't get brought on until after the grant had already started. So the original application data actually didn't even have Medicaid IDs. So we've gone and worked backward and populated those to the degree that we can. But we've still got some data gaps there. And in order to really do this right, we need to be able to have those defined. So to really move forward with that, we're looking at doing a post implementation survey of our providers to the extent that we can. Teresa's going to talk a little bit about that on the next slide. We met
In
with
November. Oops, go ahead. I'm sorry.
Oh, I was just going to say we met with we have a data subcommittee that's part of the group at WEF. And Teresa, you want to kind of talk through what we decided with?
In November, we actually met with the data subcommittee to present the data gaps analysis that we had identified. And then they helped to provide some key recommendations for us. They discussed the timing of the survey, comparing January to April in order to avoid reporting overload with the providers. They also emphasized the need to clarify and define criteria for identifying the pregnant and postpartum patients, as well as seeing a consistent range for children and youth, likely up to 18. Additional suggestions included extending hours as an access metric, and then collecting MPI and Medicaid IDs to support the accurate data matching for us. The committee also recommended incorporating some questions on the electronic health record systems and cybersecurity needs, being mindful of the survey burden while making some essential questions required, and considering equity throughout all of this and the impacts such as language barriers. Based on this feedback, we went ahead and shifted the planned survey launch to April, and to better align with the provider capacity and approve some response rates. So this is kind of documented in the slides that you're looking at that I just reviewed. What we wanted to make sure is that we had a broad spectrum of looking at what we thought our gaps actually were and how did we create a plan to be able to address that. We can move to the next slide. As we mentioned, we updated the survey based on the data subcommittee's feedback. So to close the gaps we identified, we've added a few required data points in the demographics section. And these included items such as the clinic's name, the Medicaid ID, and the city and zip code for each clinic location. We've also been collecting information on staffing and patient services to better understand the capacity across the grant cycle. We're asking for information on how many full-time behavioral health providers were hired at both of the start of the grant and at the end of the grant, currently and at the end of the grant. And also, how many behavioral health providers did they have funding for? Which is going to be an issue that we are addressing now, but looking at forward to when the grant expires and where providers can go from there. Having this information is going to help us to identify which clinics are struggled with hiring behavioral health providers, which I think Dr. Dickinson clearly outlined was an issue and a challenge. And finally, we're going to ask for the number of patients who are pregnant or postpartum, along with many of them that receive behavioral health services. So if you look through here, there's the demographics, but really I think some of the key pieces here are looking at how many providers did you have funding at the beginning of the grant cycle and how many do you have funded now? How many of them were hired at your clinic at the beginning and how many do you have hired now? How many patients did you see that were pregnant or postpartum? And how many of your pregnant or postpartum patients receive behavioral health services? These are going to be key indicators of impact for us as we continue. Can I get the next slide, please? And there's some additional survey slides, which we're also looking at identified additional data gaps related to patient demographics and the use of technology. So we've added a few more questions to help close that gap. And these include the number of patients who are children or youth and how many of them receive behavioral health services at the practice. We're also asking about the average number of monthly behavioral health related visits. Covering in-person, that will include telehealth, therapeutic interventions, and psychiatry. We're also including a question that asks whether access to behavioral health services increased based on our shared definition of access. We've also added a question about the use of technology and whether it's been helpful in supporting behavioral health services. All of this is still a progress in work through this process. And we'll continue to refine these questions and the survey as we go along. Anyone have any questions or comments about the survey questions? Okay, thank you.
Moving to the next slide, kind of talking about our next steps here. As we're moving forward on to the survey that we're going to do, our focus is going to be finalizing it and then emailing it out to everyone and making sure the survey gets distributed to the participants. As I mentioned, it's going to be in April. Our goal with this is to have as little impact as possible on the practice's operations. It's going to be a pretty quick survey. It's just a front back type situation. Shouldn't take it more than 10 or 15 minutes to fill out. So we're really optimistic that we'll get some really good responses. Some of that information that's on there, we can actually validate in some of our own resources, obviously, but we would like to see, kind of what their impressions are of how they're seeing their patients and their work move forward. So once the response is corrected, we're going to be analyzing the data using a combination of descriptive statistics, t-tests, ANOVA, to identify meaningful patterns and differences. We're going to combine that with part of the reason why we really want those Medicaid IDs is we actually have, I believe you're all familiar with quality measures and how those function. We can look at those quality measure performance rates across time, going all the way back to SIM days. Which is kind of cool. We haven't really been able to do a lot of that longitudinal work, and that was actually one of my real big disappointments when SIM ended. Is that, oh shoot, we're not going to get to see what happened in a few years. In this case, we're going to, which is kind of cool. So we'll also calculate year-over-year growth rates, understand changes over time. Conduct some subgroup analysis. such as comparing rural and urban clinics to gain deeper insights into how different populations are experiencing behavioral health services. By the way, if anyone has any questions, feel free to throw your hand up. I'm glad to take them on the fly. So next slide, please.
Hey Nathan, maybe you showed this before, but I just didn't see. But I wonder when you're looking at the practices, like what they're, rural, frontier, all those types of things. But sometimes I think about like how much a practice, how much Medicaid a practice takes versus how much commercial. Are you looking at that at all? Sorry, I missed that.
Yeah. I talked about that I talked a little bit about it on the first slide. We didn't get that deep
Okay,
into it though. But yeah,
gotcha.
no, we're definitely looking at that. Now that was one of the observations I made early in this is, we have the whole on our median is about 50-50. But we have practices that see very few Medicaid patients, and we have some that are almost entirely Medicaid. So, that's one thing. And then also the Medicare piece as well, I mean, is something that we're gonna dig into as well. So, yeah, no, it's a pretty critical piece. So, thanks for bringing that up, Cassie. Um, so for next steps, with the data we have, which is 2021 to 2024, as far as this project's concerned, we're going to be exploring how it impacted underserved populations, like those that are listed under the equity impact category on this. We submitted a data request for 2025 data. That's kind of what's holding us up right now. I don't know if you guys are aware, there's some internal changes on measure calculations going on with HICPUF right now. They switched measure engines, so we're working with them to get through that. But because of that, things are a little bit delayed. Our final report isn't due till December, but we intend on delivering a quantitative report in July. That'll kind of begin some of that work with a more complete version of that being submitted in December. So. As we continue to refine our report for those of you like Cassie who are involved in the 1302 grant, please give us any feedback or and Tara, if you'd like us to come back in July once we have the quantitative report done, we'd be glad to do that, and we love to take any guidance as far as an additional analysis that anyone would believe might be valuable. Can we go to the next slide, please? Right. To that end, Cassie, you had some great feedback actually when we did this presentation a few weeks ago. We dug into some of your suggestions actually. So I'm going to talk a little bit about that. For one of our final steps, we're focused on how we'll determine whether access to behavioral health care actually improved through 1302. Along with the survey data we'll collect, we're also going to look at Steve. I think you're on the call somewhere. I can't see you right now. I know we were kind of digging around.
Yeah,
Hey, how's it going? We're digging a lot
not
of.
bad.
Good to see you again. The health professional shortage areas data that you guys have on your the provider. I think you've changed your name too. It's no longer the provider directory. What do you guys have a new name?
Well, yeah, it's never officially the provider directory. It's the Colorado Health Systems Directory.
There you go. So
Yeah.
we're going to look at some of the data that we found on there, looking at the health professional shortage area data, which determines regions, with significant shortages of access across Colorado. It'll give us a clear way to compare progress in high need areas versus the rest of the state. We're going to use HPSA data to highlight shortage regions, track how access indicators shift across the grant years, with what we're hoping to do. Then we'll measure annual changes in behavioral health visits, staffing levels, and population served to see whether clinics in shortage areas improved at a faster rate or slower rate than the non-shortage areas. We'll also hopefully be able to look at workforce capacity, analyzing whether HPSA area clinics were able to hire and retain behavioral health providers, one of the core areas of the grant in addressing the statewide workforce shortages. Unfortunately, my analyst who's doing a lot of this work right now is on a project overseas. But Steve, once she gets back, I'd love to work with some of your staff to kind of talk a little bit more about, get more into the weeds with it. She'll be back next month, so I'll probably reach out at that point. So thanks for the suggestion too, Cassie. I appreciate it. So, I think that's kind of it. Want to go to the next slide? Does anybody have any follow-up questions or anything that they want to talk about, or questions or suggestions, ideas where we could go next?
Nathan, do you know if a copy of this goes to the legislature, or is this
So
all HICPUF's purposes?
this is for HICPUF to use in their legislative report, actually, is the big goal. HICPUF's going to use a lot of this information in their legislative report. I don't think the actual report that we'll turn in will go, but they'll do a summarized version of it and use information from it to write their legislative report. So
Okay, I thought that's part of this.
yeah.
It's been a minute since I've looked at that bill. And is the like focus on pregnant and postpartum, is that part of the bill itself, or is that something that was determined? Is that kind of your own metric around equity?
No, there was actually some specifics around pregnancy, postpartum, and youth in the bill, and we wanted to make sure that got captured. That was our big concern once we got brought on, is that we were seeing some data gaps there to be able to support, the legislative report. So
I have a quick question about that legislative report. Sorry.
yeah, go ahead.
I know that they submitted a legislative report in January already. So is it like they do an update?
Yeah.
Is that how it works? Okay.
Yeah, they'll have to do another one next year. So they'll do an update of that and resubmit. I think actually in the one that was submitted this January was actually, hey, we don't have a lot of answers yet. We'll give you more next year. As I understand it, Britta Frugland and her team, who I know sits on this committee, but she's not able to make it very often. Unfortunately, she has a meeting with her executive director at the same time. Is who that report goes to, who we work with to make that report gets done. So. All right. Any other questions from anybody? All right, guys. Thanks. Appreciate your time today.
Thank you.
And I also would like to add, we're going to miss you, Perry.
Thanks, Nathan.
Yeah. All right. Well, yes. Thank you, Perry. Thank you, Nathan. Thank you, Teresa. Thank you for all this great information, all of this amazing data. We know where to find a lot of you, Perry. We're not going to pluck you out of retirement, but we will start hitting up Mark and maybe share his personal cell so people can make data requests directly to Mark Wrights at the university. All right. Well, we will let you all go and shift to the remainder of our agenda. I mean, you're welcome to stay if you would like to, but really appreciate your time this morning and all the great work.
Thanks, everyone. Bye.
All right. Looking at the time, we're going to go a little bit quickly through our remaining agenda topics, but I think we can still probably hit everything that we need to today. A couple of quick announcements. Hopefully you all got the email. Your report was posted as required on February. It was actually the 17th this year because the 15th fell on a Saturday, but great work to all of you. A huge shout out to CHI for also helping us with that. I will note one of the follow-up items coming out of that was interest in creating a slide deck that could be shared, that you all could use for potential presentations that or conferences that you're going to. So in kind of going through some of the different comm strategies that had been raised at our meeting in February and talking with the co-chairs, this one seemed to elevate to the top as one that was pretty useful and also pretty feasible. So the division is working on that right now, and we should be able to share a draft with you by the next meeting. I think we're going to kind of leave it. It's kind of a shell and a framework you can use. I think we will, certainly you can adjust it as needed to fit to whatever purpose you need, but we'll get that out to you. Wow, by April. It's crazy that I'm saying things like that we're already in March. Meeting minutes. We got one posted. December meeting minutes are posted. I apparently did not make the link on the website when I thought they were done. So that went up last night. So you have one set of minutes to approve. We will get January finished and out there. And then we're really going to focus on February and March for you to approve at the April meeting. We wanted to get December and January finished because we think they're important in terms of transparency. They really reflect your deliberative process as you are writing the report. But we will be getting caught up. Third bullet there, new role at DOI. I forgot to tell you this at the February meeting, but for those of you who have been astute, if you look at my signature block, I have actually had a change in title. So earlier this year, about mid-January, I stepped into the role of Behavioral Health Director at the DOI. So that involves working with and overseeing some of our work around enforcing mental health parity requirements. For the foreseeable future, though, you are stuck with me here. I am still the division's primary person that is working on primary care, so you will still see me. I will still be facilitating these meetings, again, for the indefinite future. I see a great amount of overlap between those roles, right? I think in terms of and what we were just hearing within primary care, there's a lot of behavioral health integration. So I'm excited. I actually kind of advocated and wanted to keep both under my wheelhouse. We will see how that goes. Kind of how things shift at the legislative session. We will be expecting some changes in DOI leadership probably within the next year with a new governor. So all a little bit TBD, but all to let you know that that I have taken on that role. So if you hear me referred to that way, it's not a mistake, but I am also still your primary care person. Finally, quick membership update. We, I think I've contacted everybody. There may be one or two outstanding emails that I need to send. With your term, right? Saying this was the date you started, kind of this where you're at in the process and kind of getting your input on, hey, I would like to continue. I think it's probably time for me to roll off. A couple of you have some other commitments that you need to go do. So I wanted to at least stick that on your radar. The next thing we're going to talk about coming up is our standard operating procedures, and term kind of lengths is one of the items there. So as we go into that discussion of term lengths and what makes the most sense in terms of initial years and reappointments, wanted you to have kind of an idea of where you're at in that process. After this meeting, we'll circle back with you. So for those of you that know that you're going to be rolling off, we'll work with you around a transition plan, and we'll get kind of a better idea of how our membership is going to kind of be shifting over the next several months. Questions, comments about any of our housekeeping items? All right, so turning to our standard operating procedures and rules of order. Man, who doesn't like a good wonky conversation about rules of order? One of the initial things, we shared a draft version of this with you, and I think one of the initial things that we wanted to chat about is term lengths and how long do we think an initial term should be? Right now, we have an option for reappointments of 6 months to a year, and right now in the current rules, we say that if we're having a larger transition, some of you were kind of done on an annual cycle starting June or July, which came back to when the collaborative was first established. So if we see a bunch of members that are going to be transitioning off, one of the things was we want to have at least kind of a core set of about a third of you that would be kind of familiar with things and help get newer people up to speed. So I can kind of pull that section up. So right now we have members will be initially serving a 1-year term. And then in the initial language we had, and then you could request a 1-year reappointment. As time has evolved and people have wanted to stay, we've said, great, if you're still interested and have time to serve, we will let you do that. And we've had enough space to add new members. So that cycle has kind of worked fine. So with some of our edits here, we would kind of take away that total of 2 years, which now is currently in the operating procedures, or at least have the conversation. If you want to go back to that and, hey, we think people should be on a 2-year cycle, that's also fine. And then kind of some planning around notifying members prior to your term extensions. Polly, jump in here with your thoughts.
Yeah, thanks. I really want to echo what I see in Cassie's comments there, that 1 year is so short. It took me until year 2 to really understand what was happening. I'll just be honest. And especially because there's an annual report writing requirement. Like you're either coming in, it's partway started. It's just, there is a lift here to really get in the groove of no matter how well you manage us, because you do really trying to catch us up. But a year is, you're going to be, in many cases, working on part of 2 reports. And that I think is just difficult. So I would advocate for the 2-year initially, and then maybe 1-year extensions. And I am about to roll off having extended multiple times.
Yeah. Thanks. I appreciate that comment. Amy, jump on in.
Yeah, I'm gonna third that. It took me 2 years to really figure out exactly sort of, as Polly said, sort of get into the groove and understand the work well enough to be able to speak to it. So I think the first term should definitely be 2 years.
Great. Anybody against that shift to 2-year terms? Okay, I think that made a lot of sense to me and seeing that. So I think we will say an initial 2-year term. For those of you who just joined, if that was not what you signed up for, we can also chat about that. We will not make it mandatory that you have to stay for 2 years, but I think that makes a lot of sense. In terms of limiting time on the collaborative, how do folks feel about that? Right now we had now I would think it would be more than 2 years because that's your initial term, but are people in favor of that, or does it feel right to go to kind of a more flexible, right? You can ask for a reappointment and kind of leave it there rather than necessarily having an end date established in your SOPs. Amy, hop in.
Yeah, I think one thing I would do is actually rely on you guys at the DOI to say what voices are missing. And I run a couple of committees, and we have rolling terms of 3 years with the expressed call out of you can only serve a certain number of terms because we want to make sure that new voices get included. And so I think in some ways I would rely on the DOI to say what voices are we missing and how do we incorporate those voices.
Okay, no, that makes sense. Other thoughts there? Okay. 6 months to 1 year extension is kind of our current process, which I think has worked relatively, again, right? I think there can be some flexibility around what this looks like, particularly around when you started, right? We've had several of you start kind of off cycle because we've had an opening or you had found out about the collaborative and applied kind of not at a either beginning of the year or middle of the year cycle. But I think kind of the opportunity to say, hey, I would like to serve another year or another 6 months has generally worked well in terms of adjusting membership. So I don't know if people have thoughts about that, or do we want to go to something like, hey, you would serve an initial 2-year term and then you can, extend for an additional 2 years and having an extension be more of a set period of time rather than kind of leaving that as flexible.
Having a set period of time to re-up seems like it might be easier on your end, Tara, or just DOIs in general, because then you're not sort of scrambling to replace people at an ad hoc basis. You can do it at a regular time per year. But I think the burden would mostly fall onto you if it was ad hoc. So it feels like maybe you should have more of a say in that decision.
Yeah, I mean, I think we can manage all right? I feel like we've been doing this a little bit more flexibly and having that 6 year and 1 year, and I feel like it has not been overly forced. So I think we are willing to do. I mean, they're at any time between kind of 18 and 22, 23 of you. So it's not completely unmanageable. It's not like we're trying to manage 50 different membership terms. And now I have Matt, who is fabulous, so, at least for a little bit. Okay, so I see maybe a set time for an extension, and I see a 1 year extension as a suggestion. I got a thumbs up, so maybe we kind of go with that, and that's what we initially write up. And again, we can adjust these at any time, right? These are not ever set completely in stone. Okay, and it sounds like kind of the policy of having a core set of members, about 7, that would kind of be on at any time if we are seeing a bunch of transitions, also still seems like something that people feel like that feels about right.
Sarah, I forget. Does it say anything here about like when members would start, or is that just like a rolling start?
It doesn't specify here, and that has really been on a rolling basis, just because we've had enough openings and have been able to put up. I think it's worked well to have. Initially, we had only opened the application at certain points during the year. We now have just a live link on our website where people can find it at any time, and I think that's helped. Maybe drive some people who are looking at our website. So I think it's nice to kind of have that option.
Even if we don't say it, do we have a specific time that members feel like would be the best month to have folks come in? I feel like we have that loosely said.
It doesn't seem like we have a set time, but it seems like it's best to come in like right now after you just finished a report. I mean, maybe we can ask the collaborative members who've come in at kind of weird times, like in the middle of report writing, but seems to me it would be really hard to like jump in and give feedback if you haven't had the like all of the presentations from the months before. So I don't know.
No, I agree, Cassie. I think because you can read that and then begin your time. So it was really helpful for me when I came on that I could read the previous report and get a feel for, some continuity of the topics. I think that's a good time.
And I know that's feedback we had heard from a previous member
Yeah.
who came on in like November and was like, well, this was a little bit
Yeah.
crazy. So I see our two newest members here, Risha and Christina. So they got on board, like their acceptance letter, I think was either November or December, but I warned them. I said the next two meetings, there's going to be a report, like it's going to be on the screen. We're going to be wordsmithing. So you're welcome to listen in if you would like to. But so I think in terms of transitions that we know are part of that was based on when they had submitted an application. And so if there's somebody good that's interested and we want to do it, I would rather make that connection at the time that their application is newer versus waiting. But I think in terms of for some of you or people who are transitioning off of, I think that can be something we would be mindful of as we're thinking about finding a replacement to like, hey, it'd actually be better to have you kind of transition off in March or April rather than waiting till October or, September. Okay. What else did we have here to go over specifically? Right now for meeting frequency and location, the potential edit was to actually right now put our time, the second Thursday of the month from 10 to 12. I think we could also edit this to say meetings will be held virtually at a date and time approved upon by the collaborative, if you wanted to go a little bit more general. I don't know if people feel strongly about that.
It seems nice to make it flexible so that if you had to change it in the future.
Okay, that makes sense to me. Oh, all right. Two more quick things. Co-chairs. Thinking about timing, one of the edits that we had included in the draft that it would be at the first meeting after the submission of the annual report, people who wanted to serve as co-chair, like this would be a good time to determine your co-chairs for the year as well. So at this March meeting, we would determine that. And then kind of in April, we would elect whoever was interested in being co-chair. So they would have kind of that continuity and be in that role for about a year. So does that make sense to folks?
Yes.
Okay. And I know I don't believe our current co-chairs have been in for a year. So we can renominate them and do that if we want to get on this cycle, but it just seems sense that this was one of the things that made sense to do. All right, so we will make that adjustment. And our final question to put in front of you was adding a section here. Right now we have recommendations and reports to the commissioner and the General Assembly. So here you all may individually or collectively provide recommendations to the commissioner at any time, right? Your big deliverable is a report, but if there's something else that you want to put forward, you are welcome to do that. And then we are on Division staff will help you with the annual recommendations report. There was a comment here. Would we want to add any other additional communications regarding that report, or any other communications you guys would want to maybe put forward? One of the suggestions and priorities for this year was thinking about how can we be making primary care more consumer friendly, which might open up different types of materials that you guys would want to put out. So the question is, should we stick in something around additional communications in this section?
My comment was like, you know, at this time after the report comes out, should that be a good time for where we had that discussion last time, right? Where we finalized it, like, um, uh, hey, everybody, how are we gonna get the word out about this report? What's everybody gonna do? Like, what's our action item? So not necessarily detailing what we need to do in the bylaws, but like have a discussion about what we want to do with the report. Just like a placeholder to say we should discuss it every year.
Amy, go for it.
Yeah, I actually really like that idea, Cassie, and I think it would be great to also hear sort of some feedback too about where it's being received, the feedback that is coming because of it, or anything that happens because we're sharing the report in various places.
Yeah, exactly. Like, what impact are we having, right? Like, that's what I want to know.
Yeah, like you don't want to write a report and have it sit on a shelf.
Okay. We can come up with some language there and get
I
that
mean,
in.
we essentially did that last time, right? And that's how you kind of came up with the PowerPoint shell. And I thought that was a really great discussion. And these are really important points and topics that our legislators should know about, that our, you know, providers should know about, that health plans should know about. So, so just think like every year thinking about how to get the word out in different ways.
No, I like that. Okay. Did anybody have comments or questions on anything else that was tagged in this document? A lot of the rest of it was just updating with our current person who is at the division, or kind of adding in your new statutory charge. So the rest were really just kind of technical updates. Those are kind of the most substantive issues that we had. Any other thoughts or comments? All right, we will get those cleaned up. Thank you all. Thank you, co-chairs, for helping us get a good draft in place to share, and we will get those finalized and posted on the website. All right, going to keep federal and state updates fairly short. Just looking at time, some of the things that we are seeing on the Fed front, a lot of announcements, a lot of focus on fraud right now. We saw a big action taken in Minnesota against freezing Medicaid funding that was happening. They're announcing a 6-month moratorium on certain durable medical supplies. And then we also have a new RFI for the CRUSH initiative, comprehensive regulations to uncover suspicious healthcare. So there's certainly a lot of announcements, things coming out of CMS. We're seeing kind of doubling down on fraud and a fraud narrative. In terms of vaccines, things that we've seen since our last meeting, there have been 2 new appointments to ACIP. I believe they are both pediatricians. We have also seen that the meeting in February was canceled. That's still chaos around meetings getting scheduled and actually happening. This one was due because they missed a deadline to notify the public. I believe there's still one that is happening next week. I have not seen that the March meeting has been canceled yet, but it is still slated to be next month. So I would say kind of ongoing confusion or I don't know, confusion, chaos, a lot of movement in the vaccine space that is happening. The access model is one of the new CMMI models that we had talked with you about just wanted to kind of flag that a lot of the big payers out there have announced that they will adopt outcomes-based payment structures that are aligned with this model. So we're seeing that with payers that offer Medicare Advantage, Medicaid, and private insurance. So this is, again, the pledge here is to adopt a payment structure that's going to be aligned with how Medicare is paying in this model. And kind of those alignment components that they have released so far, that means alignment around certain reference documents. So how these provider agreement structures are set up, around billing codes and specific codes that will be used in this model, and then alignment around how reporting occurs in this model, which would need to be FHIR-based. So this model, again, is slated to start in July, and then the payers are at the anticipated alignment should be in place by January 1st, 2028. And then also the CMS 2026 Quality Conference is something we kind of flagged for you in past years. That is also happening, good grief, that is going to be next week. There's still an opportunity for virtual registration for those who want to turn in and hear the latest from CMS about what they're thinking around quality and quality initiatives. Questions on any of the federal announcements, or does anybody have anything that they would like to put on people's radars?
Tara, I just put in the chat. Oh, sorry. Go ahead.
Go ahead.
Oh,
Go
I
ahead,
was just
Cassie.
wondering which of the 14 major payers in Colorado are on that list.
I don't actually know that, Cassie. I can look and see.
I'm also curious, Tara, do we know how many employer-sponsored insurance plans have pledged to be a part of this?
That is also a good question that I don't know the answer to. I have seen a general announcement about it, and then I will admit to being on vacation the last week, so I didn't look that back up again, and it's not fresh in my memory. But let me find out. That we'll put that on an update where we can provide you with some additional information that shows that breakout a little bit.
I'm also curious, like for these payers, are they rolling this out across all of their patient panels, or is it just select groups that they can then say, well, we've got, 5% of our members are in this model and we can say we're part of it?
Another great question.
Patrick, is Rocky going to participate in Access?
I know nothing about Access. So can't add much value here, but I'm certainly intrigued. And if I have any insights I can share that are meaningful or valuable, I will. But this is news to me, honestly.
I think there are 11 that have been announced this year, Patrick. So not being up to date on all new models is, I think, understandable.
Yeah.
Okay. State updates. There was a HCCLF webinar about coverage, eligibility, and implementation that they hosted last month. The reporting and slides are available there. Kind of some of their strategies for looking at budget issues, which we have talked about previously. Just a note, Colorado CDPHE has recently submitted an application to join WHO's Global Outbreak and Alert Response Network. We're seeing other states start to do that since the U.S. has withdrawn from the World Health Organization. Colorado is now one of those states that we're seeing actually want to apply, so that we still have access to some I would argue, very important public health data. And then finally, legislative updates. I think we are up to about 518 bills as of this morning. That does include resolutions. We've seen about 56 that have been PI'd, so definitely in the swing of things. I will note from our list so far, one of them has actually on that PI list. This was the Consumer Protections for Medical Care Entities. This was the one that was looking at consolidation and increased reporting requirements around certain types of transactions to the state attorney general. So that one is not moving forward. I would note the bill around immunization on the list of Senate bills that we had is already through the first chamber. So kind of we flagged those that are moving along pretty quickly. That includes the immunization access. The others are still in play, just a little bit earlier in the process. Again, this kind of bigger bill around mental health access that would create an enterprise and allow most adults in Colorado access to 6 behavioral health. Don't believe that one has even been heard in committee yet. There is still a bill around parity for non-opioid pain management, and then out-of-network health insurance dispute resolution. So those are all that are still on our radar. In terms of in the other chamber, those that started on the House side, House Bill 1002 is that provider participation in health insurance. That is the one that involves credentialing for behavioral health providers. So that is another one that has passed the House, is now in the Senate, so is making its way through. I will note that the DPC bill is sailing through pretty quickly. I think votes have not been close, certainly in the House. So we see that one continuing to move through the way. It will start in the Senate. Still a bill out there around AI in healthcare, which would look at the use of AI for utilization management in the commercial space, and would also look at preventing the use of chatbots for mental health services. And then we have kind of the two other bills that we talked about around Black maternal healthidity, and a bill that would make screening for kidney disease mandatory. So all things we're still continuing to track. I don't know if anybody has any other bills that have come across their desk that they would like to raise. Looks like Chuck may have already found yes, some information about access in the chat. So thank you. All right. Any questions about federal state updates? So we are looking at having 7 minutes left to go through your priorities, which is not going to be enough time to get through all of the survey. So I will go ahead and share this with you. What these slides have done, I have taken kind of your comments previously, what you said around your reflections on your involvement and contributions, how we can best support you. I would say the overwhelming theme that the division heard here is trying to be, I think we have been mostly good about getting you materials about a week in advance that includes an agenda and some readings, really some suggestions here around getting you specific discussion questions, which is, I think, something we can work on with the co-chairs in advance of the meetings, right? In addition to just agenda, what are the actual feedback? What are some of the questions, whether that's thought questions or specific discussion questions? So we will certainly take that back and be using that to kind of inform how we're prepping you for future meetings. Some of the issues and topics that were most on top of mind for you all. And then kind of where you had ranked some of the priorities that we had offered for you. And then what you had suggested as additional topics. Some ideas around speakers and research. So we will continue to go through this. Alignment payment parameters. One of your duties is annually making recommendations on any changes to the aligned payment parameters. Heard the majority of feedback here is that we should still be using standing meetings because this is the second year of implementation and there's some activity happening in the measure space. We may think about adding a subcommittee or potentially a different type of meeting structure where we could be getting the collaborative specific feedback. But again, the idea that materials in advance are important here and allowing opportunities for written feedback are certainly things that we will take back. And the other piece that I want to make sure we have time to kind of get to was looking at the comprehensive primary care strategy, which to me, I think is going to be what the division is likely going to focus on over the next week and maybe our first initial meetings of this year. If we're going to be meaningfully moving forward with kind of putting together a broader framework for a primary care strategy, I think that's something where we need to be having those conversations and making those partnerships and kind of doing that outreach now so that we can be kind of then moving and iterating on that as we move through the rest of the year. I feel like if we wait to start thinking about this until the summer or fall, we're not going to have made much progress by the time we get to our next annual report. So I think certainly setting aside some time at the next meeting to be clarifying goals, which was what the highest rated priority around this project. And then thinking about some Colorado and national based data sources that we can be talking about, maybe revisiting some of the lists of potential metrics and things that we had talked about prior to the report, and seeing what those look like and starting to filter those. So a lot of information for you to look at in the slides, so you can kind of be thinking and digesting as you're reviewing this. If you have any other ideas or really priorities that you want to be sharing with us, you always know where to find me. You can just email Matt and I, or your co-chairs, Cassie, if that feels better. And then we will come prepared with a kind of our draft calendar format that we set out at the next meeting that we can discuss, so we can be kind of thinking about how we want to be pacing out the rest of our year. Any last minute questions or comments?
Tara, the last time, this is Risha, the last time we chatted, sorry, I'll get off. There we go. Now I'm on video. Sorry, I ducked out of another meeting to attend this one. But the last time we met, we had talked about maybe doing some work trying to identify how PCPs in the state of Colorado are employed, like how many are in private practice, how many are in independent physician agreements, how many are employed by health systems, et cetera. And so there was interest, I think, from the group on this. So I actually reached out to some colleagues, and the folks at the Massachusetts Health Quality Partners have created something called the Massachusetts Provider Database that has mapped this for primary care physicians in Massachusetts. They've been doing this for, I guess, a couple of decades, and it's considered to be gold standard and is used in a lot of academic and policy work. And the CEO agreed to meet with me and to sort of walk me through how they've done that. So I just wanted to offer that as an opportunity if you or anyone else on this call wanted to attend the meeting that I had set up with them to understand their processes.
Amazing. Yes, I would very much be interested in that. My guess is a couple of other people will too. So Risa, I'll follow up with you offline, and we can see what that looks like. Thank you.
Okay. Sure.
Any other thoughts or comments that anybody else wanted to share? I know we had prepped you saying we were going to talk about priorities. So if there's something you specifically had in mind, please pipe in. And Christina, I see you here too. I apologize. Christina was actually a participant in the 1302 grant. Sounds like you were, Cassie, as well. Would love to set aside some time at the start of the next meeting to talk about that. I know we heard about the evaluation and the data, but would love to get a practice perspective on kind of what that felt and looked like. So we will set aside some time to do that at the next meeting. We just kind of ran out of space today. Oh, you were on the advisory board. Okay. Christina, I think your practice was a grant recipient, right?
Yes. Yeah. Happy to do that next time.
Awesome. Great. Thank you. All right. Any public comment in the last minute? Although I think we're down to all members. No, I guess we do have some. All right. Well, thanks to everybody today. Glad you could join us. I hope you enjoyed the presentations. I thought that data was just really valuable to share. And we will get our gears ready to start at a running start next April. All right, go Avs.
Go Avs.
We wish everybody luck with their brackets, all of the things, and we'll see you next month.
Thanks, y'all.